Good evening, everyone. I'm Ritesh Retnakaran, uh, postgraduate in medicine from CMC Vellore. My study's name is Etiological Study of Pancytopenia, a single center experience from a tertiary care center in South India. So pancytopenia is a hematological condition with a simultaneous reduction in all three cell lines, both there is anemia, leukopenia, and thrombocytopenia. The etiology of the same could be varied from being from hematological malignancies, infections, autoimmune diseases, and basic nutritional deficiencies. So our aims was very clear. We just wanted to look at the clinical profile of these patients firstly. The other thing we want to look, was it associated with significant mortality? What was the cost of admission for these patients and how much of them recovered from pancytopenia? So we did a retrospective case analysis under a single unit of the Department of General Medicine over a period of 1 year after getting the IRB approval. With the cutoff we had set off for total counts was anything below 4,000, hemoglobin 12 below for female and 13 for male, platelet count below 1,50,000. We extracted data of clinical features, the etiology, the laboratory findings, bone marrow biopsy, whether it was done, and their hospital outcome. This was entered into RedCap software and we did analysis using SPSS. Our results showed that around 60% patients were male and 40 were female, 58.3 and 41.7, average age being 42.9, and most of the patients lying from 16 to 40 age group. And pallor was the most common noted general examination finding, which was followed by pedal edema. And the most common history finding we found out was fever and fatigue. The around 53.3% of our patients, 32 participants, underwent bone marrow biopsy, and amongst them, half of them had a cellular marrow. Around 34% of them had a hypercellular and 16.7 had a hypocellular marrow. The most common etiology we identified was a acute febrile illness, with dengue being the most common etiology amongst them. The average duration of stay of these patients was around 6 days, and the average cost, unfortunately, was the mean discharge bill was 88,000. And of these 60 patients, around two patients had mortality as an outcome. There was the etiologies were varied from AFI, SLE, TB, hematological malignancies, vitamin B12 deficiencies. We also compared between patients who had no recovery and recovery of pancytopenia. We noted a lower hemoglobin total count and platelet count amongst the patients who had no recovery. However, statistically, only platelet count was significant. Apart from the other studies, we noted that SLE was a much common etiology we found. That could be probably because of a referral bias, and AFI being one of the most common things, maybe bone marrow biopsy could be delayed. Only if we don't get a routine diagnosis, we could go ahead with a bone marrow biopsy for these patients because cost is high.
I'm a little confused from your person. You've recruited patient from general wards from the general medicine department only, isn't it?
Yes, sir.
And you have said that you did bone marrow in what proportion of people?
53, sir.
53%. And most of it is, you said dengue. Why would you want to do dengue fever with pancytopenia? You do bone marrow?
We didn't do so. For those patients, around only 53%, that is around 30 patients had bone marrow, sir. Only 6 patients had dengue.
6 patients?
Only 6 patients. 15 had acute febrile illness, sir. Amongst that, 6 had dengue. The other had scrub malaria, sir.
Only scrub malaria and all you
not done. Not
bone marrow?
Sir, only 32 patients underwent bone marrow biopsies.
See, you had 60 patients.
Yes, sir.
And we are assuming that it is all acute pancytopenia.
Yes.
Acute. Or you do not know it's acute. And you have given a very liberal definition for pancytopenia to catch the patient load. But when you analyzed, you found that their lower hemoglobin average was 7.45, agreed. Yes. Platelet count was okay, leukocyte. Now, my concern and worry is you don't have a single case of immune. Everything leukemia, plasma cell, tuberculosis, hypersplenism. There is what is immune?
Sir, SLE is there, so the chart is unfortunately not proper, sir. Here.
Not proper.
It's not coming properly, sir. SLE is the third most common.
There is no
8 patients with SLE. Sir.
AFP is acute febrile illness.
Acute febrile illness is 15 patients, followed by CLD.
Okay,
unfortunately.
so that is the one. Then, so it can't be just acute pancytopenia because tuberculosis, I don't know what it is. So classify it, acute or chronic or this thing to the best extent possible when the illness began.
Sure.
Okay, from the history you will know. Now, supposing tomorrow you're admitted or I'm admitted and I get thrombocytopenia, it's almost like an acute presentation. It can be in up to 6 months, 3 months, whatever definition you use. Fine. Second question I'm asking here is, what was the indication for any kind of product transfusion? Because I want to classify it as mild, moderate, or severe. You understand?
Okay.
So why are you given any product transfusion when my average platelet count is more than 30,000? When my average hemoglobin is more than 7? Because the worry and concern here is, why if I send you a patient with pancytopenia, it will cost me 7 lakhs
No, sir.
discharge bill,
No, 70.
80,000 for a 5-day, buy the transfusion. You can minimize the cost because you should write down what is the indication for transfusion. Because I have no indication for transfusion unless there is bleed. You agree? I mean,
Yes.
whatever your protocol is, so you should minimize the cost because cost is one of your objectives.
Yes.
So you have to tell the world it costs only 40,000 because I'm telling the world for dengue, don't transfuse unless there is clinical bleed. 10,000, everybody wants to be safe and gives a platelet transfusion. Okay, but so you'll have to look at what is the biologic and single center study and this hypersplenism, the spleen must be enlarged. You understand?
Yeah.
So you have to make. Okay, thank you.